which brings us to another topic, which is pre-certifications and even pre-procedure review, as well as making sure that the claims, when they get denied. And if you've had any kind of health care at all, and I went in for a knee surgery where I personally observed this, was that I had an MRI ordered for a knee surgery. After I went to my PCP, I was referred to a specialist. The specialist evaluated me and ordered an MRI. And the MRI was because he suspected that there was a torn meniscus in my right knee, which, through all the clinical observations of pain and, pushing the knee left and right and up and down and what have you, that was his determination. So he decided to go ahead and order the MRI. It was like $500 or whatever it was. So I went for the MRI and, submitted the claim. I then was determined from the MRI that I did have a torn meniscus, and I was scheduled for surgery. And ultimately, I had the surgery, and at the end of the surgery, probably 6-8 weeks after my surgery, I was presented with my deductible and how much my copay was and how much out of pocket, and a denial for the MRI, which seems ridiculous because if I hadn't had the MRI, they couldn't have positively diagnosed the fact that there was a torn meniscus, which led to ultimately to the surgery that was required that they ultimately did pay for. So again, they review these things. In addition to that, sometimes if you're coding, your RHIs or the RHITs are coding, if they don't put the correct code in or the code that was negotiated by the insurance company, you'll end up getting denied. And it could be just simply that they coded it wrong, that you end up with a bill. And sometimes, unfortunately, in the way things work in our healthcare system is that if you don't pay that bill, ultimately it's going to go on your credit report. The hospital's going to come after you, and then bill collectors and what have you. So as an unfortunate side consequence, I should say, of the inefficiency of our system is that even though you may need the care and you've received the care, and if there's a billing issue with revenue cycle, they misbill it, or if it goes through and it wasn't coded according to the contract with the insurance company that the hospital or healthcare organization or outpatient clinic has, it could lead to a denial. Why do insurance companies deny? Well, they want to make sure that you're following best practices or whatever their best practices are in submitting the claims, because ultimately they don't want to spend money. They want your premiums to come in, but the way their expenses are when they actually pay the claim. So they're interested in making sure that they don't have to pay the claim. So again, it's that tentative balance between our current healthcare system and the way it operates, insurance companies that are for-profit, hospitals who are oftentimes for-profit, and the care of the patient. And it seems like there is at times a direct conflict between the proper care of the patients and the fact that all this ends up leading to money. And when we talked about government intervention and some of the requirements that are in the HCA, for example, that it covers a certain number of things in order to be HCA compliant, that's because we're trying to balance out the needs of the patients with the needs of the insurance companies to make a profit, the hospital make a profit, and of course our patients to be provided the best care that they deserve. One of the other challenges that healthcare faces is pricing transparency. And if you go in to get your car serviced, you have a list of prices for whatever vehicle that you may have. So if it's an oil change, it might be $50, $80, whatever it is. And if it's a larger vehicle, it requires another quart of oil, it's a little bit more. Or if it's a import, if it's a specific filter, what have you. But you do have a certain amount of pricing transparency when you go to get brakes or, what have you. Going to the grocery store, you're purchasing some items from the grocery store, the prices are listed right there, and even on a price per unit, so you can somewhat comparison shop between the value of two specific items that may be two different sizes. Well, as of January 1st, 2019, hospitals were required by law to post some of their most common procedures and the fees for those, the cash prices for those procedures. And what we're finding is that hospitals are not as compliant as they should be, or that it's buried and not easily found by patients. Traditionally, what happens is during these negotiations with insurance companies and even with CMS is that they come to an agreed price for a service because it has a certain amount of whatever. It's very challenging because the prices are so different. That's where you hear about the $100, Tylenol. When you get Tylenol for a few pennies, why does it cost $100? And there's only a certain amount of, well, it's also covering the cost of the nurse and the professional requirement, the pharmacist to review, the doctor to prescribe it, etc. But at the same time, it's not very transparent. Even going into my aforementioned knee surgery, I got a facility charge, then I got a surgical charge, then I got an anesthesia charge, and I got like a fourth charge for something else, and I can't remember what it was, whether it was PACU monitoring or, perioperative, backpack, some sort of monitoring or something like that was completely separate. And from a consumer standpoint, it's really challenging to go in there. And oftentimes, we're not going in there to get an oil change. We're going in there because something has happened, where we admitted through the ER because of a car accident, or we have a cardiac event, 911 is called, and the ambulance shows up and takes us to the nearest available hospital, not necessarily the one that's in our network. And if it's not in our network, then we have to show, while we're in a disease state, injured, hurting, family grieving, or certainly our life is disrupted, that we have to then show our insurance company of why we didn't go to an in-network hospital for an inpatient stay. And that's where some of the things like EMTALA and patient dumping kind of came from, was the federal government wanted to make sure that that wasn't happening, that hospitals that had something that was having emergency, that they weren't just dumping that patient prior to making sure that they're stable to a facility that would be able to take care of them, that perhaps carried their insurance or had their insurance. They wanted to ensure that they were being reimbursed for services being offered. So again, that's part of that government legislation that we talked about earlier. But yeah, pricing transparency has always been an issue, and that's also the challenge for anybody that's in revenue cycle, is trying to decide or trying to come up with the schedule or working with the schedule that has requirements as far as what insurance companies build what for what code based upon what set of circumstances that have already been agreed upon by the facility and the insurance company, and how those can be different from insurance company to insurance company, and even with CMS and Medicare and Medicaid. So